Hey guys, welcome to part 14. Let's jump right into tubulointerstitial nephritis. So this comes into really two flavors of nephritis disease. There's allergic and there's crystal induced. Okay, so you can have nephritis or inflammation of the nephron in the kidney through either an allergic mechanism or a stone, crystal induced. Okay, and allergic interstitial nephritis is interesting because it has a whole host of drugs that can cause it. All right, there's rifampin, there's sulfa drugs, and then there's the 5 Ps, which are PPIs, painkillers or NSAIDs, P pills, which are diuretics, penicillins, and phenytoin. So PPPP, the 5 Ps, I like to remember them for allergic interstitial nephritis. So a nice acronym for this is RSVP, where the V is 5. So rifampin, sulfadrux, and V5Ps. Okay. NSAIDs are very common on test questions for this kind of stuff. All right. This is a type 4 hypersensitivity reaction. Don't get confused. It's T cell mediated. It's type 4. All right. So you need an original exposure, and then the T cells will become hyperactive on the following one. And this is very common with people with, for example, osteoarthritis that are on taking constant NSAIDs, and then all of a sudden, their creatinine bumps, their BUN bumps, and you realize that they could be having allergic interstitial nephritis. Sometimes there are systemic symptoms like fever, rash, flank pain, but occasionally it can be asymptomatic as well. How do you diagnose this? Well, usually there's going to be pyuria in the blood. That's the presence of WBCs. You can also have microscopic hematuria. Typically, eosinophilia is also in that pyuria, so you're peeing out white blood cells with the predominance being eosinophils, and microscopic hematuria, so some white, some red. And on biopsy, if you choose to do one, you'll see diffuse interstitial T cells and monocytes. So remember, this is type 4, so the T cells are the ones that are causing the damage. Alright, so whenever this happens, you give IV fluids, you discontinue the drug that's causing it, and it'll tend to resolve. The next one is the crystal-induced interstitial disease, right? Crystal-induced kidney injury. This is caused by other drugs, a whole other set. Acyclovir and indinavir, these are great ones. Ciprofloxacin, methotrexate. All of these drugs can cause crystal-induced nephropathy. I would remember acyclovir because it's so common, and methotrexate's one that I don't know if it's in the sketchy, but definitely watch out for methotrexate. I've seen tricks on that. And ciprofloxacin. Fluoroquinolones can do this, right? So, and everybody knows indinavir. Honestly, I think the test writers watch sketchy, and if it's not in sketchy, they're more likely to test it just to mess you up. So watch out for those extra drugs that I mentioned, methotrexate and ciprofloxacin. So these drugs have low solubility in urine and tend to precipitate, causing this kind of problem. You'll get renal colic, which is like an on and off sort of pain with the stones forming and passing, and then eventually some of them might get too large and obstruct. And you'll definitely see crystals on microscopy. Again, to treat this, you're going to discontinue the drug and give IV fluids. Okay, so we talked about these two cases of interstitial nephritis, which are allergic and crystal. These are acute. You can also have chronic cases where you have repeated insults to the nephron. And these are things like analgesic nephropathy and multiple myeloma. So myelomic nephropathy. You can also have things like cadmium, lithium, lead that can cause this kind of chronic nephropathy, as well as systemic diseases like SLE, sickle cell, Sjogren's, multiple myeloma. All of these can cause a chronic interstitial problem. But let's talk about the analgesic nephritis first, because NSAIDs are your main culprit there, and as well as acetaminophen, which, as you know, is not an NSAID, but it's linked here, right? And then these NSAIDs, they inhibit prostacyclin synthesis, right? So you get vasoconstriction of the medullary blood flow, papillary ischemia, and eventually necrosis, and that's how you get your nephropathy. You'll see the same pyuria that we saw before. You can also see hematuria that's painless, and you get possible colicky pain, but sometimes it can be go on and be asymptomatic. All right, and many times this chronic nephritis can progress to ESRD. So it's very crucial that once you've diagnosed this sort of problem, you take them off the med, and you watch out for things like ESRD and urothelial carcinoma. Multiple myeloma nephropathy is caused by precipitation of light chains in the renal tubules, which causes, again, toxicity. In these people, you're going to see oliguria, so they're not going to be peeing as much. They're going to have less urine output because those light chains are obstructing the tubules. And once you treat the multiple myeloma with chemotherapy, this should kind of resolve. Okay, but sometimes it does progress to renal damage and dialysis for the person. Another thing that I think is also important to talk about is renal papillary necrosis, since we're on this topic of renal damage. These can range from a whole host of issues. NSAIDs cause papillary necrosis as well. Cirrhosis can cause necrosis through hepatorenal syndrome. You can have sickle cell, that's a very common one, or other types of things that can obstruct the urinary tract also are a suspect for necrosis in the papilla. And you can diagnose this on CT. You also have things like tuberculosis, which can cause papillary necrosis, analgesics, like we talked about, NSAIDs. Vasculitis is another great one. So watch out for those whenever you see muddy brown or bloody casts in the urine. Acute tubular necrosis is a good one. It's a loved test question, let's just say that. All right, so now that we've talked about a little bit about kidney stuff, let's move on to a more, I think it's an interesting topic, migraines. So I love to see the test question on migraines where they have, oh, this person has a migraine, they give you a classic presentation, and then they tell you, what do you do? And then they'll try to trip you up between prophylaxis and abortive therapy. So abortive therapy treats the migraine on the spot, and prophylaxis is what you send the patient home on to prevent future migraines. Okay, so migraine treatment, I think, is pretty important. So abortive therapy, let's start with that. So stopping the migraine on the spot. There's a couple things you do that are not medication. You limit stimuli, loud noises, lights. You you start them on IV fluids. You treat the nausea and vomiting, if present, with things like metoclopramide, and you also then give things like NSAIDs. So that's the first line. First line abortive therapy for migraines, NSAIDs, acetaminophen, ASA. You can also give it in combination with caffeine, and that usually helps. Okay, and then if the first line therapy is, it's not a mild migraine, it's pretty severe, or the first line doesn't help, you jump to triptans, sumatriptan or ergotamine. Okay, so first line's NSAIDs, second line's triptans and ergotamine. These are all abortive therapies. So the person has a headache right now, you want to stop it right now, these three drugs. Okay. For second line, if let's say you don't have a triptan, or you can't use one because of fear of something like a history of serotonin syndrome, you can use butorphanol. Butorphanol is an opioid, and it's a very common second line that's asked on these kinds of questions. So another thing that's very important, sumatriptans. Let's say you have sumatriptan and ergotamine, and you say just give them the whole drawer. You can't, because sumatriptan and ergotamine within a 24-hour period, if they're given in the same time, is a dangerous drug interaction. It can cause coronary vasospasm, which will give you a heart attack, and it can also cause serotonin syndrome. So do not give them together. Do not give abortive therapies together. You can give NSAIDs and triptans, NSAIDs and ergotamine, but not sumatriptan and ergotamine. That's a very key important point, and it's high yield. Okay, so both sumatriptans and ergotamine work on serotonin, like we talked about. That's how they can cause serotonin syndrome. They bind the 5-HT receptor. But there are slight differences. So actually, another key thing, they're both abortives. They both act on 5-HT. Sumatriptan has a little bit more of a wide use. You can use it in inhibition of trigeminal nerve nociception. You can use it in cluster headaches. That gives me an idea. Let's talk about cluster headaches next once we've talked about this. So migraines and cluster is sumatriptan. It's a little bit wider used. It's more common, so you're more likely to see it on a test. Watch out for the coronary vasospasm. That's a very common question. Actually, in my hospital, I know of a case where someone, instead of getting PO sumatriptan, they got IV because there was an error made, and the person started clasping their chest, having difficulty breathing. That's all that vasoconstriction and vasospasm you see. So watch out with the mode of administration of sumatriptan as well. That's from personal experience. Okay, and also both of these are contraindicated in pregnancy. So if you have a pregnant woman, don't give triptans or ergotamines. You are out of luck. Okay. All right. So we've covered our abortives now. Let's talk about our prophylaxis. So prophylaxis, again, you can do the lifestyle things: exercise, healthy diet, avoiding triggers. Regular sleep is also a great one. People with irregular sleep cycles tend to get more migraines. And you give people prophylactic therapy if they have more than 2 attacks per month, or their attacks are severe and debilitating. Okay, so that's kind of the cutoff. First line here is anticonvulsants, things like topiramate, things like valproate. Beta blockers are also first line. Propranolol is a great one, metoprolol, timolol. Okay, so anticonvulsants and beta blockers, A, B. Second line is TCAs and like amitriptyline. Okay, so first line, anticonvulsants and beta blockers. These are prophylaxis. So abortives are different from prophylaxis. Anticonvulsants, beta blockers are prophylaxis. So they prevent the migraine from happening. All right, so that's pretty much all I wanted to say about migraines. And I said we'd talk about cluster headaches. So treatment of cluster headaches, extremely highly tested, okay? They'll give you the classic, oh, the person has unilateral headache with pain behind the eye and tearing. And the first line therapy, oxygen, 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 oxygen. I've got a billion questions where the answer was always oxygen. FiO2 of 100%, give them oxygen, okay? You can also go ahead and give them sumatriptan. Or if they don't want to give you sumatriptan because they think that's too easy, they'll give you another triptan. Mostly it's going to be zolmitriptan. Okay, so triptans are also first line for cluster headaches. Don't get confused. Oxygen and sumatriptan can be used for cluster headaches. Sumatriptan can also be used as an abortive for migraine headaches. All right, I hope this has been pretty clear to you guys and can help you out. For prevention, verapamil here is the key drug to look out for. Verapamil, verapamil, verapamil. Okay, so calcium channel blockers, cluster headaches. The two C's go together. Migraine prophylaxis, beta blockers, and seizure drugs, the BS. You know, you can think of migraines as BS because they really suck when you have one. Okay, so that's the treatment for cluster headaches. Next, let's talk about another great exam topic, gout. So gout, treatment of gout. What do you want to do? So identifying gout's not going to be the problem on the test. It's usually going to be one joint problem where the person has some kind of risk factor for gout. And then they'll tell you negatively birefringent crystals on exam. So treating gout, lifestyle, limiting alcohol. Alcohol competes with urate in the tubules to get excreted. So definitely take it out of your diet. Limit purines. Don't eat red meat. Don't eat shellfish. Stop high fructose corn syrup because it can damage the tubules as well and cause urea to be reabsorbed too much. And then weight loss is also a great one. Okay, so those are the lifestyle modifications you can do. The pharmacologic stuff, which they're more likely to test you on, what do you do for a gouty attack, and then what do you do for prevention, right? So first line agents for pharmacotherapy of gout are going to be steroids, NSAIDs, and colchicine. Don't forget the steroids, okay? NSAIDs and colchicine, everyone likes to throw those out. Steroids is a good one. They often like to put it on tests as the right answer. I just got a question today. The answer was steroids for gout, okay? Intra-articular or PO. Don't forget you can give PO steroids for gout as well. Okay, second line, you can use IL-1 inhibitors and ACTH. I've very rarely seen second line drugs ever being mentioned on testing questions. Even on wards, people don't usually tend to go for them, okay? So another thing is if you combine NSAIDs, let's say you have a patient with gout, if you combine NSAIDs and steroids, make sure that person's on a PPI because you've just put them at a very high risk for a GI ulcer, all right? So NSAID steroids, bad for stomach, give PPI. Okay, which NSAID to use? The very common one that's thrown on tests is going to be either naproxen or indomethacin. Those ones are like candy for the test. Naproxen, indomethacin. Okay. You can also use selective COX-2 inhibitors if those if the ulcer is a really big problem for you. Okay. Another key thing here is that you can use aspirin, but in a higher dose, but low dose, like extremely high dose aspirin can show benefit in gout. It's not really used, but low dose aspirin can actually decrease uric acid excretion. So if the person's on a low dose aspirin, they're taking 81 milligrams just because they heard it was good online, you can discontinue that. But if they're on low dose aspirin for something real like coronary artery disease or cerebrovascular disease, if they've had a diagnosis and they're doing that for prevention, then you don't discontinue the aspirin. You only discontinue it if the patient's taking it just for fun or because they've heard it's good for prevention. Okay, you want to help the uric acid escape. Low dose aspirin does not do that. So colchicine is great because it binds and stabilizes tubulin, causing macrotubules to be inhibited, and therefore, you know, your phagocytic cells don't really work, and the inflammation from the urate crystals being eaten up isn't there anymore, or is reduced. All right. If you're going to give colchicine, it's not really going to work if you give it more than 36 hours after symptom onset. So if the person's been having gout for a day and a half, 2 days, not really going to help you much to give colchicine. It's really preferred in patients who cannot tolerate NSAIDs or steroids. NSAIDs and steroids are more of the golden boys for gout, but colchicine is thrown around a lot, especially on tests. Okay. If you give colchicine and the person's on a statin, you do have to monitor for myotoxicity, right? Pravastatin, atorvastatin, stimvastatin, all of those. If they have a gout attack and they're usually going to be on a statin because they're usually overweight, you want to monitor for myotoxicity, muscle CK, right? Okay. Now, we've talked about those drugs that are for acute gout, the NSAIDs, the steroids, and the colchicine. Now, what do we do for chronic gout? So we're going to have to do urate lowering therapy. And usually when you start urate lowering therapy, any of them, you want to pre-treat with the acute gout drugs, NSAIDs, colchicine, steroids, because actually starting these drugs up can actually predispose you to a gouty attack. Okay, so definitely 1 week before you start the urate lowering therapy, make sure they're on the pre-treatment for that, which is, you know, NSAIDs, the steroids, the colchicine, to help them not precipitate a gouty attack. All right. So, what are the drugs involved in urate lowering therapy? And when do you give them? So when you give them is for if the person has tophi, if the person has frequent attacks. What does that mean? More than 2 per year. That's frequency in gout. If the person has CKD, really high uric acid of higher than 9, or has had uric acid stones in the past, you can also consider giving it. Okay. And the drugs are allopurinol, febuxostat, probenecid, and pegloticase. Now, the first two, allopurinol and febuxostat, those are xanthine oxidase inhibitors. They're going to prevent the formation of the uric acid. Okay, they're going to inhibit the purines from being metabolized into uric acid. Also remember that in the purine metabolism pathway, you have azathioprine and 6-mercaptopurine. And these are cancer drugs that if you give them with xanthine oxidase inhibitors can be really toxic because their levels build up really high. So you have to adjust doses in people with these drugs because you can precipitate toxicity. Watch out for that. Another important thing that I've seen tested a billion times is that allopurinol, before you give it, you also have to test for HLA-B5801 allele, especially in Asians. These people tend to get allergic reactions to allopurinol that are very severe, and you want to watch out for that with HLA-B5801. Very, very important. Tested like a billion times. Stevens-Johnson is also something you need to watch out for with allopurinol. All right. And then febuxostat is another first-line agent. They might throw it on the test as an alternative. Okay, so the other drugs I mentioned, the second-line drugs. Probenecid is a second-line drug if you can't use a xanthine oxidase inhibitor for whatever reason. It inhibits uric acid reabsorption in the kidney, so it's going to cause you to pee it out. You can actually precipitate more stones with this, so remember, watch out for that. You can cause uric acid stones, that's the main side effect. Okay, and pegloticase is a enzyme that catalyzes the increased breakdown of uric acid to allantoin. It's also extremely helpful. All right, so just to quickly summarize, let's go through the gout prophylactic agents for chronic gout, the uric acid lowering therapy drugs. So that's going to be your allopurinol and your febuxostat, which are xanthine oxidase inhibitors. Watch out for the HLA-B5801 for allopurinol, and also watch out for azathioprine with allopurinol, because in combination they can lead to something called bone marrow toxicity. All right, that's very high yield to remember. Then for the second line agent, that's probenecid. That's going to be your alternative to xanthine oxidase inhibitors. Basically, it inhibits uric acid reabsorption in the kidney and can cause kidney stones from uric acid. Okay, so that's a proximal convoluted tubule inhibitor of uric acid absorption. It can also inhibit penicillin excretion in the proximal convoluted tubule, so you can cause hypoglycemia, so watch out for that side effect as well. Pegloticase is also a second line drug. Well, it's more like a third line drug. It's really used as a last alternative if you're not able to control the gout. It essentially causes uric acid breakdown to be increased to allantoin. It catalyzes the breakdown. It works kind of like a enzyme, and it has no real extreme side effects. It can have anaphylaxis. It needs to be given in the clinic with infusions, so it's not exactly convenient, and it's really third line as a uricosuric. Okay, now let's move on to another topic, pancreatitis. So pancreatitis or pericarditis, pericarditis. We'll cover pancreatitis in another video, but in this topic review, I think we should go over pericarditis treatment because we've been on this theme of treatments. So let's continue with treating pericarditis. And pericarditis has a bunch of causes. Either things like radiation, uremia is a great one. Myocardial infarction is also extremely high yield. Remember, you can get pericarditis in 2 separate time frames after a myocardial infarction or MI. You can get it in 1 to 3 days, which is called post-infarction fibrinous pericarditis, and you can get it within months, which is called Dressler syndrome. So both of those time frames are relevant for MI pericarditis. Then we have neoplasms like Hodgkin's lymphoma, rheumatoid arthritis can also cause it, lupus, scleroderma. These are just a bunch of causes for pericarditis. How do you treat it? Well, it's funny enough, we have our 2 friends from gout treatment popping up again, colchicine and NSAIDs. Right? This disease is often self-limited, so even if you didn't give anything, it would likely go away. But NSAIDs are kind of first line. Aspirin, ibuprofen, and indomethacin, all of those. You can consider combining colchicine with NSAIDs, and you can also consider prednisone. So this is a big throwback to similar drugs we've seen with gout. That's why I thought to include this as part of our gout treatment aside. Okay. Very important to know about pericarditis is that beta blockers and calcium channel blockers should always be avoided in constrictive pericarditis because they can worsen heart failure and slow compensatory tachycardia you need for your heart to function during a constrictive pericarditis. Alright, so when would you see pericarditis? Let's say the person's on dialysis, you can get uremia from dialysis, boom, pericarditis after that. That's a very common one for tests. Okay, you have to always try to determine the underlying cause, because treating that will also help reduce the pericarditis, and you can also know about it in the future, right? If you have a bacterial cause, treat with antibiotics. If you have a autoimmune disease cause, give steroids or immunosuppressants. All right. So that's pretty much it for pericarditis, I think. Another thing that I think we can stop here, and then in the next video we'll cover things like meningitis, which is extremely high yield. What other things do I think are high yield? We'll do some infectious disease. I think covering some of the DNA viruses are going to be high yield on the test because they're important. So we'll do meningitis and DNA viruses for sure, and then some other random topics. Alright, I'll see you guys in the next video.